Oh, all right. Tonight, William E. Gandy, Gene Gandy, is going to be substituting for Dr. Frame and Dr. Eschenbach tonight. Dr. Frame was exhausted and he's sleeping right now, and Dr. Eschenbach is on shift right now. So in the interest of making sure that we still have good roundtable discussions for the P2 students especially, Gene has graciously offered to step in. Of course, he's not a physician, but he is a JD, which is a fancy name for lawyer as well as paramedic. And he's been in EMS longer than God, I think. So I think you'll get a really good lecture here over left ventricular assist devices, which are becoming more and more common in dealing with in the field. So I think this is going to be an excellent lecture. That having been said, I am going to mute my microphone and let you have it, Gene. Good luck.
Okay, what I'm going to show you is a video that's about 43 minutes long. It's from Wisconsin State EMS, and it's one of their things about LVADs. It's done by the LVAD person from St. Luke's Hospital in Milwaukee, Wisconsin, and it's really good. I know that you'll have some questions and everything about it. So if you can just kind of jot down your questions and everything, then when we finish, we can talk about questions and issues that come up. But I think this covers it pretty well. So with that, I'm going to start the video.
Hi, I'm Kathleen Schultz. I'm a clinical engineer at Aurora St. Luke's Medical Center. I've been working there for 10 years with the ventricular assist device program, and I'm here today to tell you a little bit about our devices and how you may interact with them out in our community. When we talk about a left ventricular assist device, we're talking about a device that is going to take over some of the function of their left ventricle. It works in parallel with their native heart. So we don't remove their heart, we basically core a little piece of their left ventricle out and put in one of our devices. Then the blood that goes into their left ventricle is then pumped through our device back into the aorta and pumped back into the rest of their body. It does take over the majority of the function of their left ventricle, but not all of it. They still will get some blood going from their left ventricle into the aorta through the aortic valve itself. At St. Luke's, we currently use two different types of non-pulsatile VADs. We use the HeartMate 2 and the HeartWare device. Both of these devices are able to have the patient go home on them. When we talk about devices and why we use them, there's a couple reasons. There's one called a bridge to transplant. With a bridge to transplant patient, these patients ultimately will be transplanted at the end of their device life. We are basically putting in a device to make them healthy for when they go into transplant, because we want them to be like you and I. We want them to be able to walk as much as they can. We want them to be able to exercise. So it's basically to build their endurance back up. We also use bridge to transplant devices in our very large type O patients. Type O blood type patients are a little harder to transplant, so they're on that transplant list a little longer. Unfortunately, the length of the list also causes them to often become sicker in their heart failure. So we're able to put these devices in, and we're able to give them a better life until their transplant comes. Now, kind of the way the whole VAD world and transplant world is going is that most patients who will get a transplant will be on a VAD before transplant. It's just kind of how it's going. We've noticed that the healthier we can take them into the transplant, the better off they are with their transplant, and their transplant surgeries go a little better. So at St. Luke's, probably about 75% of our patients who go to transplant have an LVAD prior to it. And again, they can be discharged home. The other indication that we're starting to use now, and it's been approved in the last probably about 10 years, is destination therapy. Destination therapy patients are not transplant candidates. There's many reasons why they may not be transplant candidates. It could be their age. At St. Luke's, we have kind of a soft cutoff of 70. We do some patients over 70 if they are very physically active patients, but most of the time our cutoff for transplant is 70. We also, if they have a lot of health conditions, we may not be able to transplant them right now. whether they have renal failure, whether they have cancer, you know, other things that may cause them to not currently be able to be on the transplant list. Well, we don't want to promise those type of patients a transplant if we can't give it to them. So what we do to them is we say, oh, we can still put this pump in as destination therapy, but we're asking them to bear with us and see if we can fix their health condition. And then when their health condition is fixed or becomes at a point where they can be transplanted, then we move them back over to the bridge to transplant list. Compliance is another huge issue. We are advocates for the donor family. We are not advocates for our patients. So we want to make sure that our patients are 100% compliant and that they're going to treat their new organ with the respect that it deserves. So if we have any sort of judgmental issues with our patients on their ability to be compliant with medications, alcohol or drug use, things like that, we may actually say, you know what? You have to prove to us you're going to be compliant, and then we will give you a heart. So we basically do a social contract with them and say, these are the things that you have to do. And when you fulfill that social contract, we then will move you back over to bridge to transplant. The other reason that we may put it in for destination therapy is obesity. If somebody is over a BMI of 40, which is basically a ratio between their height and their weight, if it's over 40, we can't transplant them. It's too hard to find them a healthy organ. So then we say to them, you know what, we will put this device in you and we will give you the ability to go out and exercise. We'll educate you on what you need to eat, and you need to come back to us and show us that you're going to lose the weight you need in order to get that transplant. We also are one of the only programs in the nation who actually also has a good relationship with gastric bypass. So a lot of our patients, if they're really obese and they're showing us that they're doing what they need to do, we actually will refer them to our bariatric program to get a lap band, or usually only a lap band because it causes issues later with transplant if they have a full gastric bypass. But we do have a program with that. All of patients who are destination therapy, they're at high risk of intervention, high risk of death if we don't intervene soon. Usually the protocol is if we don't do something and put a device in them, their life expectancy is about 6 months is what we're looking at. These patients will live on this device. They are never promised a transplant. They're given basically contracts and say, if you follow these, we will go ahead and possibly move you over to that transplant list, but you really have to prove it to us. So when they're put in, we do give them a palliative care consult because we know that they could die on this device. That might be their end all. They could eventually, again, move to that transplant list if things get fixed, and then they can be discharged home on these devices to live on them. Currently, at St. Luke's, we are about a 50-50 in our bridge to transplant and our destination therapy list. Now, when we talk about these new types of devices, before we get into them, I want to just talk about what non-pulsatile devices are. When I first started at St. Luke's, our devices were about the size of a paint can lid, and they were about 2 inches thick. So imagine putting that in a patient. That was pretty big. It was all motorized and it would break in about 1.5 years. So the companies and the healthcare world said, you guys have to do something about this. So in order to make them smaller, we had to make them what we call non-pulsatile. So basically when we talk about non-pulsatile, our devices have no valves in them. So they have no ability to close and shut. It's just one opening that goes through. With that, the easiest way to kind of picture it is like water coming out of a garden hose. We call it continuous flow. So whatever the device gets, the device is going to spit out. When it comes out of the end of our device, or what we call our outlet, it is also going to have no pulsatility to it. It is seriously like water out of a garden hose. So with that in mind, our patients will have very, very low blood pressures, and their difference between their systolic and their diastolic pressure is pretty small. We're looking at about a 5 to 15 millimeter of mercury due. And that difference in that, what we call pulse pressure, the difference between the systolic and diastolic, is literally just on their own heart and they're contracting. So that's what causes that difference. But again, we minimize it. So there is no usually blood pressure of 120 over 80. You know, we're looking at 90 over 70, 80 over 60 sometimes. We're looking at much lower blood pressures. They're typically not palpable at the extremities, so even though it may have a little bit of pulse pressure when it leaves our device and hits the aorta, by the time it gets out to their arms and their legs, if you try to feel pulses, they're often diminished or gone. So it does cause a little bit of problem for our people who meet them in the community because they're used to feeling a pulse, and our patients often don't have that. The patients still do need their native heart. We did not take it out. We attached these devices to their native heart. And for our devices to work and work effectively, we really need that native heart to still pump. So we're really dependent on still that contractility that that native heart has always had. And we will try to correct the heart if it's not functioning right, because our device will see and have problems with that. Similarities among all of our VADs that we use, even the ones that I'm not going to show you today. We do have some at the hospital that maybe don't go home or are a different kind that we rarely use. But all of our devices will have what we call a drive line. And this is basically a line that exits their body, usually on the right side. And this is what delivers all the power to the device and actually allows the device to communicate back with us. This drive line is very, very important that we keep and maintain it. We don't want any cuts in it. We don't want any breaks in it, because if we break things, we break the wires, we break the communication, and we break the ability to provide power to it. All of our devices will have a controller, basically the brains of the system. It's like a little mini computer. It's all programmed. It's what tells the pump what to do, and it also is what reads what the pump is doing and gives you visual and audible alarms if anything is wrong. So it has 2 batteries. They will all have a battery charger, and they will all have some sort of AC power unit for sleeping. Basically, all that is a unit that plugs up into the wall and provides the patient continuous power so that when they're sleeping, they don't have to worry about running out of battery power. What we do at St. Luke's, though, is we encourage our patients only to use that wall unit when they are sleeping. We did not have them go through this big surgery that requires a full chest opening for them to sit on a power unit and not get out and exercise. So we tell them, when you get up in the morning, you need to get on batteries, and you need to stay on batteries all day so that you can go ahead and be living life and going to the store and going out to eat and going to be with your family and friends. Again, the types of VADs that we're going to talk about today are our 2 most common types. It's the HeartMate 2 device and the HeartWare device. When it comes to which one we choose, it really comes down to a couple things. Usually the physician will choose based on the patient's size, their heart failure. Sometimes it depends on if it's in a clinical study or not. If it is in a clinical study, sometimes the patient may not qualify, so they may be forced to the other one. If the physician really has no reason to choose one device over the other device, we actually show both to the patient. We show them what they're going to take home, how they're going to have to live, give them a small synopsis of how it functions, and we let the patient choose what they feel will fit into their lifestyle the best. When we talk about the HeartMate 2, this is currently the most common LVAD that we do use at Aurora St. Luke's. There is a picture on the screen with it, but here is the LVAD also. What happens is it does take over pumping for the left side of the heart. This is what we call an inflow right here. So when I talked earlier about coring out that left ventricle, basically it's almost like an apple core. We just go in there and we take out a small piece of the ventricle in which this inlet can fit in. We basically then pop this into the inlet. All of this pump stays down just below their rib cage inside of them, and this is our outflow in which we go ahead and we sew right back to the aorta. So we're taking the blood from the left ventricle that it normally would have used. We spin it through our pump, which is this gray portion right here, and we put it right back where it should have gone, the aorta. Again, this is the drive line. We've talked about this a couple times, this white cord. So basically this is going to tunnel underneath them, come out on the right side of their body. And this is what you will see basically is just this cording piece of material from here to here. It's going to come out. So this patient only has this much distance in order to move. This pump itself is projected to last about 5 to 10 years. There is truly no contacting parts inside of here, so there really should be nothing that wears or tears inside of it and breaks, but they, just in the time of being on And what we have to do is we have to do something called anticoagulate these patients, because we put a foreign body inside of their body. Their body likes to kind of reject it a little bit. So what we have to do is these patients will be on Coumadin and aspirin in most cases, and usually that fluctuation in Coumadin and aspirin at some point in time may cause this pump to clot off. So that's where we get that projected 5 to 10 years is more how easy they are to what we call anticoagulate. When they're on Coumadin, there is a level that we can watch to see what their level is at, and that's called an INR. We look for an INR of 1.5 to 2.5 for the HeartMate 2. With that in mind, that is not any higher than a patient who is out there on atrial fib or has a valve surgery or replacement. So we're really not asking for a hugely increased INR than other common heart surgeries out there. With the HeartMate 2, some patients can be off of anticoagulation if they have a history of a GI bleed. What happens with the devices is sometimes they will have an increased risk of GI bleeding. So the HeartMate 2 does allow our patients to take it off of Coumadin periodically for that history of GI bleeds. We kind of already talked about where it exits the body. So again, just above the waistline with this drive line, this white piece that will come out of here will then attach to something called a controller. This is the controller. Off of the controller is 2 other leads. So this drive line right here will go into the controller right here. And then off of there comes 2 power leads in which they would have to have batteries or a power unit attached at all times. This is our older controller. So we actually have 2 different controllers currently out in the community on our HeartMate 2 patients. The older controller looks like this. It provides power to the LVAD still like before, controls everything. It does provide visual and audible alarms through this panel on the front here. And when the patient leaves, they will always have an extra controller with them. So in this case, if they have this controller, the drive line is actually going to attach right here. So this white line would come in right here and attach, and then their batteries are coming off one on each side. The controller actually has been upgraded to a new controller, which is the first one I had out here. The nice thing about this controller is it not only gives you symbols, but it actually gives you words. So it'll tell you how to fix it or what's going on. So there's not a lot of guesswork with this newer controller. The batteries, the patient will wear 2 batteries at all times. So this controller right here is actually attached to a driveline and running. So it has 2 batteries attached to it at all times. For a battery to interface with the controller, it does require a clip. So you just put these 2 together and go on and put it onto the pump. It does require that 2 power sources be attached to it at all times. So it either has to have 2 batteries, or it'll have the power module cable, which has 2 ends to it that are attached. Once a patient on a HeartMate 2 goes onto a set of batteries is going to last them about 12 to 15 hours. So they will actually get the majority of their day out of 1 set of batteries. Unless they sleep 2 hours a night, they really are going to get all day on 1 set of batteries. You'll see on this slide, there's also a picture of a power module. That's what they would use to provide AC power. The thing with the HeartMate 2 is this box is about 1 foot by 1 foot. It has to sit in one room. It's about 10 to 15 pounds. So the patients don't like to move it around. So it's often going to be found in their bedroom. So if you do ever go to their house and you're looking for their power module, we tell them to put it where they're going to sleep, because that's where they're going to need it. So it is often found in a bedroom. The next slide shows the universal battery charger. So again, obviously these batteries need to be recharged at some point in time. So the patient goes home with 8 batteries. Their battery charger charges 4 at a time. So they are taught to rotate through all 8 of their batteries at any given time. When the batteries are not hooked up into the charger, if they're just sitting there not being used, they will hold a charge for well over a month. So they should be able to rotate through them pretty easily. If the patient has the older controller, the manila colored controller, They will also, on top of their power module, have a display module. That is what gives them all of their numbers. It gives them all of their alarms in verbal or in written form. So they have that portion to it with that display module. With the newer controller, that's all available right there for you at that time, because that display module only works when you hook up to the power module. So it wasn't quite as convenient as the new controller. The hardware device is the other one that we commonly use. So this is the hardware device. This device is currently approved for just bridge to transplant. It is in a study for destination therapy. It's not a study based on how effective the pump is. It is more based on a study on what blood pressure you need to maintain to make this pump not clot off for long periods of time. Because again, remember that destination therapy patient is going to live on this device. So they really are looking at what is that blood pressure. Again, it works very similar to before. We still have an inflow. It sits at the top of this pump, still requires a full chest opening. The nice thing about this one is it does sit right at the apex of their heart. So not below their rib cage, but rather behind their rib cage. So if we have a shorter, smaller person, this device sometimes fits in a little better because it doesn't have to go down into their abdomen at all. I do not have the graft material on this pump, but it has the same kind of grafting material that comes off of here and goes right back to the aorta. Again, this pump is projected to last about 5 to 10 years, just like the other pump. The only thing is this one does require a tiny bit higher INR. We're looking at 2 to 3 for this device, and they're pretty strict on that 2 to 3. They don't like us to take people off of anticoagulation if they're bleeding with this device. At times we have no choice but to do that, but we try to leave it on. Again, the picture here kind of shows how it fits in there. It shows the pump right at the base of the heart. It shows the drive line. Mine's a little twisted. Coming out on the right-hand side. And then this drive line, again, attaches to a controller box. And then this controller box has to attach to some sort of power source. When we talk about accessories, again, this is their controller. The big selling point on this one used to be that it had the LCD screen, but now HeartMate 2 has come to the new century and has also given them a LCD screen. It still does the same thing the HeartMate 2 does. It still provides all the power to the pump. It also takes information from the pump and gives it back to the user. So this is what is going to provide them any of their visual or audible alarms based on if something is wrong with the pump. There is a picture of how it is carried in a bag down below on the PowerPoint. And they still are required to carry an extra one of these around when they leave the house. So basically, any patient who leaves their house should always have an extra controller with them, no matter which device they're on, and they should have extra batteries with them. A battery for this device is this small gray box right here. I'm going to pick up this whole thing. And it plugs into the controller just like this. These are a little nicer. They're just a turn and a push to get them in. It can operate, or it does operate on just one battery at a time. So even though you are required to have 2 power sources attached to your controller at all times, it is only draining one of them at a time. So with that in mind, the batteries do only last about 4 to 6 hours, and then the patient will get a little beep that tells them that they need to put a new battery on that side. Once they replace the battery, then the beep goes away. The controller will automatically switch to the other power source that's attached to it, so the patient doesn't have to run out of power. It just is notified every 4 to 6 hours that they have a low battery. The nice thing about this, which I didn't bring here, is this device does have an AC, what they call power cord. It's a lot like a laptop brick. So that cord that runs to your laptop, that's what their AC cord is. So rather than that 1 by 1 foot box, it's really a portable cord with them. So these patients, even though their batteries may not last as long, it is very portable. So we actually do encourage these patients, if they're just sitting around watching TV, why run on your batteries? Just plug into the wall, because the cord is really easy and portable to move around. We also encourage them, if they're going out of their house, to take one of their AC cords with them. They do go home with two, to have it with them so that they can hook up when they're just sitting around doing nothing. They also are provided with a DC adapter, which is something that the HeartMate 2 does not have. So these patients, if they're one of those that's going to travel, we actually have a patient that is currently on his way to Wyoming in a car, and he is using his DC adapter. It plugs into his power cord in his car, and he can hook up and run off of his car battery while he's driving to Wyoming, and he doesn't have to worry about worrying about his batteries changing, because this patient physically himself is driving to Wyoming. He is the one driving. So we don't want him to have to worry about running out of power as he's driving. About probably 50% of our patients drive. We do allow them to drive. There's nothing currently in the state of Wisconsin that stops them from driving. So they are restricted to about 12 weeks after surgery before we allow them to drive. This device also has a battery charger, just like the other device. It charges 4 batteries at a time. It allows them to, so if they get 4 to 6 hours out of their battery, it's going to take them about 4 hours to recharge that battery. This device does go home with only 6 batteries, but remember, they do have that AC cord that they're allowed to use during the day a little more freely, so they don't eat through quite as many batteries. When we talk about complications, so now we put this in, we say they're okay to leave the hospital, and we send them out to the community. What complications are you guys maybe going to see with these patients? One of the main complications that we have are arrhythmias. There's right heart failure. There's low volume, device malfunction, bleeding, infection, and thrombus and stroke. When it comes to arrhythmias, remember before I told you that our pump is really dependent on that heart functioning as it's intended, because that's what fills our pump. When your heart contracts, it pushes blood through our pump a little faster. So we need that heart to work. Remember too, earlier I told you that this only supports the left side of their heart. Well, there's a whole other side of the heart called the right side. And the right side's what feeds all the blood to the lungs, oxygenates that blood, and then that blood comes from the lungs into your left side. And then that's that oxygenated blood that your tissue and your body get when your left side pumps it out. Well, if we leave these patients in arrhythmias for long periods of time, we're going to put out that right side of the heart, and it's not going to function as it was intended. And then our device isn't going to function as well. And then guess what happens? Your end organs, your livers, your kidneys, all of those type of things, they don't get perfusion. They don't get oxygenated blood. So we can't leave our patients in arrhythmias for long periods of time. With that in tow, our patients will tolerate an arrhythmia. So you may walk up upon one of our patients and they may be in VTAC or VFib. Well, guess what? They'll be talking to you. So it's a little strange because that's not normally what you see out there. When people especially are in VFib, they're down on the ground. You're doing CPR usually. And our patients sometimes will talk to you. They may tell you they don't feel the best, but they're likely not going to hit the ground and pass out in most cases. They'll be talking. We still want you to get them out of them. So if their AICD hasn't gone off on its own, we want you to externally defibrillate these patients. Again, if the right side's not working and it can't get blood through the lungs and it can't get it to our left side, then our pump can't function. So we really have to work on that right heart failure. With that in mind, out in the community, do not underestimate the amount of patients that we may have on some sort of Viagra in some way, shape, or form. May come in different names, Revatio or Modulin. But ask even our female patients, are you on some sort of Viagra before you treat these patients? Because they often are. That is one of the medications that we commonly use to help that right heart function. It helps lower those pressures in the lungs for us so that right side doesn't have to work quite as hard. So low volume, that is another thing that we're going to deal with here. We did not cure their heart failure. Again, there's no cure truly for heart failure. All we're doing is finding a way to kind of assist their heart failure so it's not quite as overcoming to them. So with low volume, what happens sometimes is we still have these patients on diuretics. And we're limiting their intake and we're giving them diuretics such as Lasix, furosemide, things like that. So we always are bouncing back and forth on that low volume issue. So you may run across a patient who has low volume. The other thing that comes with low volume, and we're going to jump ahead a little bit, is that bleeding. So if that patient is doing some GI bleeding or bleeding somewhere else, or they've been bleeding profusely out of their nose, which happens sometimes, they may become a low volume state, and we have to supplement that low volume state. Because what happens if we don't supplement that low volume state, remember I told you all of these inflows are sitting in their left ventricle. If we don't have enough volume in that left ventricle, our ventricle kind of sucks down around that inflow, and if our inflow taps that ventricle wall at all, it often will cause that patient to go into VTAC or VFib. So we really are juggling that low volume state. Device malfunctions, I know it sounds horrible, but they actually are pretty rare. The devices are actually pretty reliable. They may get a battery here or there that goes wrong, but when we're looking at device malfunctions, they often are just a change of a controller. And most of the time, the patient can come to us and we can change their controller. It's still functioning, just something maybe isn't working 100% right with it. So often they're not even changing their controllers at home. They're coming to us. When we talk about device malfunction, the big one really is, jumping ahead again a little bit, is that thrombus and stroke issue. Because if we start building any sort of tissue up inside our pump, it can't spin like it wants to. And it starts to cause some heart failure issues with these patients. So when we're thinking that there may be some sort of thrombus in our pump, we start looking for things like Coca-Cola color urine. So if you come across our patients and they have really dark urine, when we get them to the hospital, we start looking at things like their labs. There's a value called LDH that we check. There's a value called plasma-free hemoglobin. If all of those are elevated along with that Coca-Cola color urine, plus there's a number on the device called power that we watch, if that's also increased, those are all really indicated that the patient may have some sort of thrombus building up inside of them. They also always risk that stroke. Just because we put a foreign body inside of them, they always will have a risk of stroke, in that ability to kind of build up some sort of clot and basically spit it out of our pump, and then it goes to their head or to some sort of arm or limb. With that in mind, there is also infection. I know I talked about it last, but this is probably the #1 problem our patients have. Remember, I told you earlier, we have that exit site that's coming out of the right side. Well, that's basically a foreign body coming out of their thing. If they tug or pull on that exit site, it's going to open it up. Well, as soon as you open it up, guess what? Those little bugs like to get in there. Once our patients are infected, if they have a full-blown infection and they don't call us early, it will often remain infected for the duration of their pump life. They often will end up on antibiotics for the duration of their pump life, which often becomes a miserable life for them. So we really encourage our patients to be mindful of that exit site. We actually have them wear a device a little further down from their exit site. So if they drop their bag or something like that, which is going to happen at times, it pulls on that device and not the actual exit site itself to avoid infections. When we talk about the EMS ED role, or just the community role in general, we do want you guys calling us and asking us if you have any questions. So anytime you come across a patient who may be having a problem out in the community, we do ask that you guys use the numbers that are on the controllers. On the hardware controller, the numbers are going to be on the back of the controller. And on the HeartMate 2, the numbers will also be on the back of the controller for you. Those numbers will give you the EMS, or it'll give you all the pager numbers for the engineers. It also gives you the surgeons and the transplant clinics numbers. So you have full access to us at all times. When the patient does go home, we do notify their immediate community that they are out there. So if the patient lives in Milwaukee, we notify the Milwaukee EMS. If the patient lives in Racine, we notify the Racine EMS. So if the patient lives in Waukesha, we'll notify Waukesha's EMS. But remember, these patients aren't homebound. They don't have to stay home. Remember earlier, I said we have a patient going to Wyoming right now. So we then also notified Wyoming. So if they travel, we ask that they let us know that they're traveling so we can set them up with the safest way to travel in centers out and about. But again, you know, a patient from Waukesha could very easily go to Pleasant Prairie to go shopping, and a Racine person could run across them out in the communities. So again, it is important to remember that if you need them at all, that those numbers are on the back of the controller. So if the patient can't communicate with you, you need to look for those numbers and communicate with us so that we can help you out in the community about getting them back to us. Again, the patients and the families are completely trained on these devices. When they leave our hospital, they know exactly how to run them, how to troubleshoot them, how to change controllers, how to notice if things are going wrong. It is not the community's responsibility to know how to troubleshoot them. What we like to do is come out and educate you guys so you guys can see what they are, what a battery is, what a controller is. So when you get out there, if the patient's kind of stumbling through things, you've seen it already. We do ask, though, that if you do come across them and they need to be put in an ambulance and taken to a facility, that you do allow a device-trained individual to go with them, especially if the patient is in some sort of distress, because they may not be able to 100% operate their own device at that point in time. We also ask that you try to get a hold of the engineers and let us know that you're coming in so that we can meet you in the ER, because if it's the weekends or nights, we're not at the hospital, so we're coming from home. We also ask that you really help us make sure that the patient leaves the house with a backup controller and extra batteries. I know sometimes that's the hardest thing to do when the patient's in distress. You just want to get them in the rig and get them out, but we really need that extra controller when they hit our hospital. So, you know, they may need assistance carrying that equipment. We do encourage our patients to try to keep their extra controller and an extra set of batteries in a bag ready to go at all times. So often if you just ask them, where's your emergency bag? Where's your backup controller? They'll know right away, like, oh, it's right by the door, or it's right here. So sometimes it's just a little bit of communicating with them, because they're often forgetful when they're in that distressed state. If the patient is medically stable, we do ask that you try to take them to St. Luke's. We do understand if they're not within the Milwaukee area, sometimes that's a little hard to do. So you can take them to a local hospital. That local hospital then would hopefully communicate with us, or if you can remind them to communicate with us with the numbers on the back of the controller, that they're out there, and then we will communicate with them on what is the best course of action for that patient. It's becoming more common that LVADs are out there, so now you're seeing that a lot of times our patients will go to outlying ERs and they'll actually get treated and get discharged home from those outlying ERs. It's not always necessary that they come to St. Luke's as much as it used to be. If the patient is clinically unstable, though, we really need them to go to the closest hospital, because we don't want anybody to miss a treatment because you took a 3-hour drive from Green Bay down to Milwaukee. So at that point in time, we have no choice but to take them to the local hospital and get them stabilized, and then get them transported down to us. Now, what is the EMS ED role when it comes to VADs? So if you're not a VAD trained person, what are you supposed to do with these patients? Well, we do understand that assessing these patients is very hard, because remember, again, this is a non-pulsatile left ventricular assist device. So we took away every measurement that you guys are used to using. We took away their blood pressure in most cases. We took away their pulse in most cases. So you really have to go back to things that are clinical signs. You need to look, are they breathing? Are they warm? Do they have capillary refill? Push their finger down and see how fast it takes their fingernail to fill back up. If they're talking to you, even if they don't have a pulse, please don't do anything crazy with them. Just call us and we'll help you through it. So with that in mind, with blood pressures, that's always the big question for us. What do we do with that blood pressure? Because guess what? It's not always going to be picked up by an automated cuff, which people are used to using. You can try it. We do run our devices a little slower than we used to help with that GI bleed problem, just to keep a little more pulsatility in these patients. So sometimes that automatic blood pressure cuff will work. If you do get it to work, fine, you can take that number. But again, remember, that number may not be what you're used to looking at. When it comes through that automated cuff, it may only be 80/60. I don't want you pumping a bunch of volume into my patient, because that's normally what people would do at that point in time. If you have an 80/60, we are looking for a mean pressure between 60 and 90 for these devices. So we don't treat a systolic and a diastolic with these patients. We treat a mean. So again, you may have some patients out there with lower blood pressures. If you put too much volume in these patients, you're going to push them into congestive heart failure. So again, we walk that really thin line. If you cannot get that automated blood pressure cuff to work, Sometimes it requires that you use a Doppler. And what you would do is you would put a normal manual cuff on their arm. You're going to blow it up. You're going to put the Doppler where you would listen. And when you hear that first swoosh sound, guess what? That's the number you're going to take. You will not hear a second number. You're just going to hear that first swoosh number. And we want that number somewhere to be 60 and 90. We consider that kind of like their systolic mean. So again, if you can't get it to automatically read, then you will have to find a Doppler and use a Doppler pressure. Now, what happens if our patient comes in and they're not stable? They're not able to talk to you. They come in, they're basically full-blown coding. Well, guess what? We made it easy for you. Follow all your ACLS protocol. You still want to attach EKG rhythms to these patients. That's one of the biggest things we see out in the community is patients who have VADs, people don't want to do the normal. Guess what? Your AICDs will work. Your AEDs will work. You want to get ECG cables on there. Make sure that they're not in arrhythmia, that that's not what's causing their problems. If they do have an arrhythmia, we want you to shock them out of it. Again, remember though that a lot of them will be awake and alert and oriented. So if you're going to shock them externally, please sedate them first because they won't be very happy with you. If you have to do chest compressions on these patients, let's say that they have no pulse, you can't find it, they're not talking to you, they're starting to turn gray, they're starting to turn cold, guess what? You have no choice. Do chest compressions. To us at St. Luke's, we have the little saying, dead is dead. So please try to save them and do the chest compressions. If you do nothing, they're going to die. Again, so we can't stress more than anything. Look at that rhythm. If you only have an AED, if they go down at church and you have an AED, pop it on them. It'll work. We want to keep them out of those arrhythmias. And again, follow all the ACLS protocol. The only thing I caution again is make sure that the patient's not on some sort of Viagra. In general, VAD troubleshooting. So again, we don't train you, but everybody wants to know, what do we do? How do we do this? You know, what do we do if we come across this patient and their controller's alarming? Well, guess what? In general, if the controller is not alarming and you come across one of our patients, they have at least 2.5 liters of flow going through them. Our devices, both devices, alarm if their flow is less than 2.5 liters. So with that in mind, you're not going to get much more with that with doing chest compressions. So unless that patient is truly turning gray and cold, I wouldn't jump into them if the controller is not alarming. If the controller is alarming, we do ask that you verify that the power source is attached. So if this is the hardware, you want to make sure that batteries are attached to it. And then the HeartMate 2, you want to make sure that batteries are attached to the power leads. In both cases, these pumps will not run if batteries are not attached. So you may come across a patient that has just accidentally disconnected both of his powers. So if there is not power attached, please attach power. If there is still good power attached and the thing is still alarming, we want you to verify that the controller is attached to the drive line. So in this case on the hardware, it's making sure that the silver connection is in the actual controller and hasn't come out. On the HeartMate 2, depending on which controller you have, it's either going to go into the top here, or if you run across some of our older patients that are out, it's going to be on the side here. So it's just making sure that that controller has not come out at all from the drive line. Because if the controller is not attached, there's no way to provide power to the pump, so the pump will stop again. If it's still alarming, at that point in time, you need to page one of the engineers at the 414-222-7434 number, and we'll help you do any additional troubleshooting that you would need to do out in the field. With that in mind, I will remind you there has been times where the EMS or the ED has had to call us and they've had to put a battery on, or they've had to find equipment for us. And this is why we do these talks, so that when I'm on the phone with you and I say, can you find a battery? You know what a battery looks like. I'd like to thank you now for assisting us and helping us get these patients back out to the community and living their lives again for us. It's huge in their recovery process.
Okay, well, what do you think? How was that?
That was good. Got a lot of good notes.
I think I've seen this thing several times, and I've tried to keep in my mind, what the biggest take-home things are. And one of them is that I had always heard before I saw this that you don't do CPR. And the reason for that is in the beginning with these things, they were so afraid of dislodging the pump from the heart. And of course, that would result in instant death. But in fact, that has not been the experience. One of the things that I saw, this was sent me by a friend of mine who is an ER doc up in Pittsburgh. His name is Jason Kodat. He used to be a paramedic. Well, he's still a paramedic, but he's also an MD. What he mentioned was that look at your ETCO2, and if you have the patient intubated and you have verified that the tube is in the right place, if your ETCO2 is still less than 20, you probably need to do CPR, assuming that you're in VFib or VTAC. Keep in mind that your patient will be sitting up, sometimes talking to you, and you'll see VFib on the monitor or VTAC on the monitor. So you have to do, like she said, you have to treat your patient rather than the monitor. And you use all of the other clinical signs that we use to tell whether the patient's being perfused or not. And if the patient is unresponsive and the end-tidal CO2 is less than 20, and they're in VFib, and their capillary refill is non-existent, and they're blue-gray, and they are essentially dead at that moment. So your problem is to keep them from being dead until you can get them there and see if anything can be done. And that involves doing CPR, because there is no downside to it. If they're to that point, they really are dead, and we're just trying to hold it off. So if you don't do CPR, you're not giving them any chance at all. Right. So you'll hear people say, "Oh, no, you can't do CPR." These will be some of the medics who have been out there for a while and they haven't had an update. But the current thinking is that if they are to that point where there's really nothing else to be done, then CPR is appropriate.
Same with the ACLS protocols, right?
Yeah.
Okay.
Yeah, the same thing. Now, it's odd, of course, to have a patient, your patient's in VFib and sitting there talking to you. And it's odd not being able to get a blood pressure. Not everybody carries a Doppler. I don't know of a single EMS service that carries Dopplers. Do you guys?
No.
I've never seen one on an ambulance, but, if you have a good stethoscope and you put it underneath the cuff, you may be able to hear that one change in sound. And that's all you're going to hear. You're not going to hear the normal Korotkov sounds that you hear when you take a blood pressure. You may hear one change, and that would be your MAP. And here again, if you've been in my chat rooms before, which both of you have, you know that I stress in all patients looking at MAP rather than systolic and diastolic blood pressure, because MAP tells us so much more about the patient's perfusion status than systolic and diastolic do. So here again, what we're dealing with here is the MAP, and they want it to be between 60 and 90. So if you do get what you think is a good sound change when you're doing your blood pressure, that would be your MAP. And as long as it's between 60 and 90, we don't want to give a lot of fluid to them. Of course, we do want to go ahead and get lines. That's good, but you can run them TKO rather than wide open. Or you call up the technician, the LVAD tech, and they will tell you what to do. And that's the important thing. When you have one of these patients, right off the bat, as soon as you can, call the tech. It's what they're there for. And every patient probably knows that. They may have already called them for you. So the thing that's going to happen is that you're going to be surprised by this, because it's going to be that guy driving to Wyoming who got into town and something went wrong, and he's driven up to your station, or he has called EMS, and you get there and here's this patient, and the first thing you do is you reach for a pulse, and there is none. Radial, and so you look up, you reach up and you try the carotid, and there is none. And
it's wild.
And you know, it's going to knock you back for a minute because he's talking to you. But they should tell you the first thing, if they can talk, is I've got an LVAD. And so then you say, oh, okay, how cool.
Jean, Alicia has a question. She said, would calling the tech take priority over med control? Can we assume that it's what med control is going to tell us to do anyway?
Yeah, med control is going to say call the tech. So yes, the tech has priority. So, well, what do you guys think? Any other questions that come to your mind about
cardiac pacing?
Pacing?
Yes, I think it would only affect like the right side of the heart, correct?
Yeah. Well, yeah, a pacer will work. But the problem is that the heart is too sick probably for it to capture and begin to do its thing. Remember that the reason the LVAD is in there is that the left side of the heart has become too weak to function. And the right side of the heart is not going to be any better, because if you have left heart failure, you're going to end up having right heart failure. What the LVAD does is just keep enough flow going that you'll have enough venous return and enough preload to get the blood into the lungs and back to the left side, and then it takes over from there. I don't think pacing probably would work in most cases. Jane, what are your thoughts about that?
Well, it stands to reason that if you don't have heart muscle that is able to pump, that, you know, just because you add more electricity to it doesn't necessarily mean that it's going to make it pump better. But, you know, you should always, in my opinion, you should always try, you know, anything at your disposal. If the person meets that criteria, you might get lucky and hit something just right, but I don't know how beneficial it would be.
Yeah, the worst thing that could happen would be that it doesn't capture. So,
exactly. And you were saying earlier about EMS services carrying Dopplers. I don't know if they still do or not, but I know when I flew, we had a Doppler because, you know, there's so many settings when you're on the helicopter that you can't hear.
right.
So we have Dopplers on the birds, but I would assume they still do, but ground EMS not so much, but on the helicopters probably so.
You know, because I have hearing problems, I always had an electronic stethoscope, and it was almost as good as a Doppler because it allowed me to hear really well. But, you know, the thing about it is, don't worry, if you can't get a blood pressure, look at your patient. You know, is your patient nice and pink, and are their buccal surfaces and their conjunctiva pink? Do they have capillary refill and everything? If they do, they're being perfused. So, on the other hand, if they're blue-gray, cyanotic, they're not responsive, and they're in VFib, and you can't improve that, and their CO2 is less than 20, you're going to have to do CPR.
Alicia says they have Dopplers in their offshore kits.
I see that. Yeah, that's excellent. Yeah, when I worked offshore, we had one too, because the noise level out there is just incredible. I mean, the whole building shakes all the time. It's a dull roar. But anyway, all right. Well, anything further? We're up to the end of the hour, and you all know my email address. So if questions come to your mind, you can email me, and I will either know the answer or find it out for you.
I think this was great. I know that the LVADs are getting to be something that we're seeing so much more in the field, and we have to be able to know. And you know, the take home out of that whole lecture thing that I got was the same thing that I always try to enforce when I'm teaching things like the special needs patients. You know, the patients that you're going to their houses and they have IV pumps and they have trachs and they have ventilators and they have all these things at home. Like the lady there was saying, is that the family and the caregivers are very well trained on what to do if and how to manage all of that equipment. They're your best friend in the back of that truck. This is one of those exceptions, even if your service does not like for you to take family or allow them to sit in the back of the unit with the patient. This is one of those circumstances where it has to be addressed with your service that it should be allowed, because they know more about that equipment than you do. And the stupid medic is the one that tells them, no, you got to go ride in the front.
Mm-hmm.
Absolutely. Okay, well, if there's nothing further, we will say good night for tonight. I will be here on Monday for basic chat. I will be here on Tuesday, same time, same station, actually at 6 o'clock Texas time, for advanced chat on Tuesday. And so I hope you guys can join us.
Thank you, sir. Appreciate
All right,
it.
everyone. Have a good night. Have a great weekend. Thank you, Gene.
Thank you. Bye.